Hi class, this is our first adventure in recording a class lecture. So slide number 1 is a YouTube link to Elvis singing Suspicious Minds. If you haven't heard it before, it's a good one to look at and listen to. Okay, on our second slide we have a picture of Russell Crowe in the movie A Beautiful Mind. And it is the story of John Walsh, who was a Nobel Prize winner in mathematics. And very rarely for someone with schizophrenia, Walsh was able to work successfully as a mathematician while having schizophrenia. If you haven't seen the film, it's a really good basic introduction to what it's like to have a severe illness like schizophrenia. The story is a little bit adapted for the visual media. For example, Crowe's hallucinations are depicted as visual rather than auditory, which is much more common in schizophrenia, but this was because film is a visual medium. If you haven't seen it, really, I think you would enjoy seeing it. It's an excellent, well-done film, and it won several Academy Awards. All right, so what is schizophrenia? It is the most severe of all the mental illnesses. Now, you will often hear people say, oh, I feel schizophrenic about something, meaning they feel ambiguous. This is an inappropriate use of the word schizophrenia. The word originally meant a split between emotions and thinking. This is really an obsolete term, but it's nevertheless what we're stuck with, okay? Now, interestingly enough, schizophrenia occurs in about 1% of the population in every society. This is very interesting because it indicates that cultural influences are minimal on the development of schizophrenia, and that the real cause of the illness is something biological. Schizophrenia is not a moral failing, it's not moral weakness, it is an illness, a neurological illness. Now, schizophrenia occurs approximately equal in men and women. However, men tend to have an earlier onset than women. Men tend to develop schizophrenia in adolescence, while women tend to develop it in early adulthood. This gives women an advantage in terms of getting more education and job training. However, the course of the illness, once they have it, is fairly similar. All right, schizophrenia unfortunately decreases the patient's length of life. And it decreases length of life because of suicide, because of complications related to the medications and to lifestyle. For example, lung cancer is fairly common in people with schizophrenia because of their high rates of smoking. Metabolic syndrome, diabetes, hypertension is also common in people with schizophrenia because of the obesity associated with medications and associated with a poor lifestyle. I want to get back to the 1% of the population worldwide. There are certain pockets of the world where the incidence of schizophrenia is even higher, and this includes the west of Ireland, certain parts of West Africa, and among the indigenous people in Taiwan. And it's not really clear why that is, although some of it may be due to intermarriage. All right, schizophrenia is treatable. It's treated with a combination of medication and therapy. However, people don't generally recover from schizophrenia. Something else about schizophrenia, there is always a deterioration in social and occupational functioning. Wherever people are, they deteriorate once they have the illness. Okay. Schizophrenia is very costly, both to patients in terms of human suffering, but also to governments and society in terms of expense, hospitalization, and associated anxiety with being around people who act so differently. All right, now schizophrenia disturbs how people think, how they perceive the world, and how they present to the world. So their thinking processes are interrupted with delusions and alterations in cognition. People think about delusions and hallucinations as being the most troublesome part of schizophrenia, but really it's this alteration in cognition. Your thinking is not clear. You find it hard to understand the world, and other people find it hard to understand you. Alterations in perception are, of course, hallucinations, and we also see changes in affect. The way people express themselves and the way they look is different. Schizophrenia is not multiple personality. Multiple personality is now called dissociative identity disorder, and we'll be talking about that later on in the semester. That actually is a very rare disorder. Schizophrenia is not rare, with 1% of the population being affected. Schizophrenia is not contagious. Okay. Now, what does cause schizophrenia? Well, it's a combination of factors. Definitely genetics. There is a family disposition towards schizophrenia. Changes in the environment and prenatal insults seem to be implicated. Let's look at the viral theory. This is a picture of E. Fuller Torrey, and he was the psychiatrist who was depicted in the film about Marge and David. Now, Torrey did a study some years ago in which he looked at the incidence of schizophrenia in people born during World War II and shortly after in the Netherlands. Now, the Netherlands was the Western country that was most badly treated by the Nazis. Hitler thought the Dutch should be sympathetic to the Nazi cause because they were Aryans, like the Germans. They were not. And as revenge, when the Dutch did not cooperate with the Nazis, Hitler ordered his generals to starve the Dutch to death in 1944. The cities were surrounded, and no food was allowed into the cities, and the people began to starve. And the people resorted to eating their pets, including cats. Now, the cats were also starving, and so the cats had eaten rats. Pregnant women who experienced a famine in the Netherlands in 1944 were twice as likely to have a child with schizophrenia as women who had given birth in 1946 or in 1943. And the theory is that the rats had picked up a virus which was transmitted to cats, which was then transmitted to people when people were forced to eat the cats. Now, it's been well known for many, many years that there is an excess of schizophrenia in people born in winter months. And the reason is that it's maternal exposure to influenza and the virus then is transmitted to the fetus in utero. There's another reason to get a flu shot, people. The virus causes some change in the brain of the fetus. So to reiterate, people born in winter months are at higher risk of developing schizophrenia if their mother had been exposed to flu while she was pregnant with them. Let's see what else. A father over 50 years of age predisposes you to schizophrenia. And when I say the rate doubles, it goes from 1% to 2%. So 1 out of 100 risk to 1 out of 200. Because the reason that an older father is at increased risk of having a child with schizophrenia is that the longer men make sperm, the more likely there is to be a genetic mutation in their sperm. Also, maternal starvation has been implicated. There was a great famine in China in 55 and 56 because of the Communist Party's relocation of farmers from their individual farms to these huge collective farms. Many, many people starved. Women who were pregnant at the time of the famine were more likely to have a child with schizophrenia than women who had a child either before or after the famine. Maternal stress has also been implicated in the development of schizophrenia. In 1956, there was a very severe storm in Massachusetts, a hurricane, and people were cut off for extended periods of time from the towns and cities, and people experienced cold, darkness, lack of food. Women who were pregnant at this time and caught in this terrible hurricane were more likely to have a child with schizophrenia than those women who were pregnant and not had been so stressed out. Schizophrenia is not caused by bad parenting. This was a theory that was common 30, 40, 50 years ago, and it has been totally discredited. The thinking was that if you had a cold mother, that this would have caused schizophrenia, and that's not true. So it seems to be some kind of environmental insult, maternal stress, prenatal exposure to the flu virus. Okay. Now, how is schizophrenia diagnosed? It is diagnosed with a clinical interview, by taking the family history and doing a basic physical workup to rule out anything else that might be causing acute changes to the brain, including drug intoxication. One time we had a young man come in and he was floridly psychotic, and his parents were very, very worried that he was taking drugs. And the resident said, you know, that would have been the best case scenario if he had been taking drugs. Because if he'd been taking drugs, he could be treated for substance abuse. Unfortunately, the young man had schizophrenia, much worse than taking drugs, because schizophrenia, while treatable, is not curable. So, patient will have, who is newly psychotic, will have a clinical interview, but they're also going to have a physical exam with a focus on neuro symptoms, and they're going to have toxicology test, perhaps definitely for drugs of abuse, but possibly even for heavy metals. And we're going to be looking at their CBC and SMAC20 and their urine toxicology to see if there's anything else there that could explain their symptoms. Now, twin studies. We saw the famous twin study that NIH did on the film, but here is a interesting depiction of the brains of two twins, one with schizophrenia and one not. And just look at the film before, just look at the pictures before you even look at the writing. And you can see that the twin on the right has much more darker areas, like right here, indicating a lack of brain tissue. And a lack of brain tissue indicates that you have major problems. Less brain equals more illness. And I'll let you just read that. All right, now risk by relationship. I want to point out here the hereditary risk of schizophrenia. And look at what the rate is with identical twins. Over 50%, almost 60%. And yet fraternal twins, we see it's only about 15%. If you have a parent with schizophrenia, you're at increased risk. But once we get beyond first-degree relatives in pink, and then look at second-degree relatives, we see that the rate goes down, and that it's actually quite close to the rest of the population. Okay. All right, the origin of the illness. Now, poverty has been linked to schizophrenia in that more poor people are ill with schizophrenia than middle class or rich people. The issue, though, is something called downward drift. Is it that you become poor because you're mentally ill and can't work, or was it poverty that precipitated your illness? Certainly, if you have stress in your life, that could trigger the onset of schizophrenia in somebody who is already vulnerable. But it might be more than poverty. It might be also abuse, drug use, that you've been mistreated by other people, and so on. So, now there is something called the expressed emotion theory of schizophrenia. Expressed emotion means that you are living in a hostile home environment. And not surprisingly, people who live in hostile home environments are more vulnerable to relapse than people who live in supported environments. Really, that shouldn't be any kind of a surprise. All right, now we're looking at functional MRI images. And what we see in people with schizophrenia in the bottom right here is that they have less brain activity when giving what's called an executive decision task. This is like a puzzle, a word puzzle when you have to make some decisions. You can see that the brains of people who are normal, see the N over here, are highlighted in red because they're thinking, thinking, thinking. Well, the people with schizophrenia are struggling to solve the problem and their brains show less activity. And what does this show you? That there are physical changes in the brain of people with schizophrenia. They have much more difficulty processing information. So, the nature of the disorder. Okay, so we'll look at schizophrenia in terms of 4 phases. And the first phase is the pre-morbid phase. And this is before the person gets a diagnosis of schizophrenia. So perhaps a person is 16 or 17 years old, and they're in high school, and they're an odd person in high school. They're shy, they don't have many friends, and when they talk to their peers, they act in a rather odd way. And people see that there's something wrong, but perhaps they can't quite put their finger on it. They're not doing that well in school, either behaviorally or academically. And they may show some antisocial behavior, some aggressive or inappropriate behavior, but they also may show some withdrawn behavior, some asocial behavior where they don't interact with other people. So there's something not quite right. All right, in the prodromal phase. Now, in this second phase, and this takes place over weeks or even years, the person begins to go downhill. There's a deterioration. The things they used to handle competently or semi-competently, they are now having more trouble with. And now they start even to have problems in activities of daily living, taking care of themselves, hygiene, shampooing their hair, fixing a meal. They also may show a sleep disturbance. In fact, it's almost certain they show a sleep disturbance. They have trouble falling asleep. They wake up early. Their sleep is interrupted. They're anxious. They're irritable. They find it hard to concentrate. They don't feel right. And this is when hallucinations begin. They start to hear voices. They may start to see things. They become increasingly suspicious. They are beginning to have the acute onset of schizophrenia. All right, now the full-blown disorder. In the active phase of the disorder, the psychotic symptoms are very prominent. And the psychotic symptoms are the things that are clearly abnormal. And these are the delusions, the hallucinations, and the severe social and occupational impairment. They find it difficult to do the things most of us take for granted every day. They're not able to work, they're not able to go to school, and if they are at work or school, they really, really struggle with it. And it's at this stage that people come to the attention of professionals and perhaps of the legal system, because it's really clear that they're having trouble managing their life. All right, and then the residual phase. The residual phase is when people have been treated and the acute symptoms of the delusions and hallucinations are dampened, but there's still something not quite right. They still have a problem with this flat affect. they have a problem with how they interact with people. They still have some problems in functioning. Okay. Now, the symptoms of schizophrenia are most acute in late adolescence and young adulthood. Once people get to middle age, the acute symptoms of schizophrenia decrease, and the person is not as acutely ill as they were when they were younger. Now, they may have relapses and symptoms may reoccur, but schizophrenia is most severe in late adolescence, the 20s, and early 30s. After that, it tends to modify. All right, the prognosis. It's rare but possible for people to return to where they were before they became ill. Now, what factors lead to a good outcome? Well, if you were high functioning before you became acutely ill, you're likely to be high functioning when you are treated. What else? Later age of onset. Yes, the sicker you are, the earlier the disease develops. As I said before, women tend to have a slightly less severe illness than men. An abrupt onset precipitated by a stressful event, well, that suggests that if life had gone smoothly, you might not ever have developed symptoms. Associated with a mood disturbance, yeah, people who have schizoaffective symptoms, who have both cognitive problems and mood problems, actually tend to have a better prognosis. And if you've been functioning well in between episodes of illness, that's good. Brief duration, that makes sense. Minimal residual symptoms, again. And if your brain abnormalities are subtle enough that they don't show up on an MRI, that would indicate that, you know, your illness is less severe than people who actually have brain shrinkage. Normal neurofunctioning, right? And a family history of a mood disorder as opposed to a psychotic disorder. If you have a good family history, better outcome. Okay, and this is just a depiction of how schizophrenia tends to develop. And I think you can see pretty clearly that it tends to be the worse right here in this lavender stage in late adolescence, the 20s and early 30s. Okay, 3 types of symptoms in schizophrenia: positive, negative, and cognitive symptoms. This has become more important in recent years because the positive symptoms are treatable by all antipsychotic medications, but the negative symptoms seem to be most amenably treated with some of the new antipsychotics, and that's a good justification for trying them first before the older meds. And the cognitive symptoms are really just not helped very much by medications, and these can be quite disabling to people. All right, so positive symptoms. These are things that should not be there. You can think about positive symptoms as being like add-ons. Okay, hallucinations are something that should not be there, and we already talked about those. Something that the patient sees or smells or hears or tastes or feels, and there's no basis in reality for that symptom. Delusions, false beliefs, okay? So paranoid delusions are the most common type of delusion, and then there are some other various types of delusions. One we didn't talk about in class is a romantic delusion, erotomania, and that is the belief that a famous person is in love with you. And typically this would be a famous actor or actress or celebrity. And very often people try and get in touch with these people and even stalk them because they're convinced that this celebrity is wants to be with them, and that other people are interfering with this relationship. There's a misspelling here. This should be a capgrass delusion, and we already talked about that. You believe that your significant other or friend has been replaced by an alien. Catards is interesting too. You believe that you are dead, or that something has happened to you and that you're just walking around, but you're not really alive. Very strange. Oh, I did want you to hear the kinks, but I can't embed the sound in PowerPoint. So take a listen to that. It's a good song. Maybe I'll play it in class. It's about schizophrenia. Okay, now assessment. So we already talked about looseness of association, and that is very common in schizophrenia. If you talk with the patient, you can see that their thinking is kind of scrambled, and that they shift from topic to topic, and the ideas do not have a connection. Now, flight of ideas is different but similar. In flight of ideas, person jumps from topic to topic, but you can see the connection. Remember, I told you about the patient who was wearing his gown upside down and told the nurse, well, don't you know how Peter died, meaning St. Peter being crucified upside down. With looseness of association or associative looseness, you don't see the connection between the patient's thoughts. All right, and the neologisms are just made up words that only have meaning for the patient. What else do we see? We see sometimes clang associations, although really clang is probably more common in mania. Word salad, we don't see this too often. This is when groups of words are put together in a somewhat random fashion. Tangential thinking, they cannot get to the point. And then mutism, they don't speak. Not because they're unable, but they refuse to speak. Now, sometimes people are mute. They can't speak because of something called catatonia, which I'll get to in a moment. Catatonia is not a stroke. Catatonia is the inability to speak or move because you are so intensely anxious. You're frozen, basically. Okay, what else? Concrete thinking. We already touched on this with proverbs. You interpret the environment quite literally. This is a low form of thinking. Okay. Circumstantial thinking. You beat around the bush. It's hard to get you to answer a simple question because you bring in so much unnecessary and irrelevant information in when you answer a question. And perseveration is persistent repetition. Okay, so we already talked about hallucinations and illusions. Hallucinations are very common in schizophrenia, and it's really a diagnostic criteria for schizophrenia is auditory hallucinations. And of course, illusions are typically seen in people who are sick. It's a med-surg issue, not really a psych issue for the most part. Okay, echolalia, echopraxia, imitating people, depersonalization, all of these are symptoms of schizophrenia. And if you think about it, you can see how these symptoms are so diverse and so encompassing. And you can see that there really is just a complete change in the person's personality and way of thinking. All right, these are 4 pictures done by an artist. We start at the top left right here, and we see this nice looking cat. And as the artist, Louis Wayne, became increasingly ill with schizophrenia, you can see the deterioration in his paintings. And you can see how his whole perception changed so radically as he became more ill. The world is a very scary place if you have schizophrenia. Think about looking at this cat in the upper left and then this cat in the lower right. How frightening it would be if this is the way you perceived your pet. Okay, negative symptoms. Negative symptoms are things that should not be there. And one of the things about schizophrenia is that it takes things away from people. Okay, so let's start out with flat affect or affect. It's fairly common for people with schizophrenia to have trouble expressing emotion. And when they do express emotion, sometimes it's inappropriate to the situation. They lose their sense of what is appropriate to feel and how to behave in different situations. Okay. Apathy is also very common in schizophrenia. There's a lack of interest and engagement in the environment, a lack of enthusiasm. And one time, well, I shouldn't say one time, but every fall, the recreational therapist at the hospital would get so excited when the football and basketball games would come on Saturday. And he would try and get the patients to be enthused about watching the game, and we're going to have popcorn, and it's going to be so exciting. And everybody, come on now, all you U of L fans, all you UK fans, we're going to have a great time. And he just couldn't not get any interest in the patients. It was kind of sad because he was something that most of the staff and most of the people in society were excited about, and they just couldn't enjoy it. Apathy is very common. All right, volition. This is something else. People with schizophrenia tend to lose their drive and ambition. This is part of this whole detachment from the world. And many people slip into this sip and smoke syndrome, where they drink coffee and smoke cigarettes and have a hard time engaging in the world. This is something that nurses are responsible for in the milieu, is to get people out of their room and talking with others, developing social skills, and learning to have some enjoyment in life. Now, ambivalence. This is also a negative symptom. Ambivalence is the problem of not being able to make a decision because you have both positive and negative feelings about the same situation. And so you can't make any kind of a decision. Let me give you an example. Years ago, at the old Central State, we were on the fourth floor. And one day, there was a picnic. And it was a picnic for all the staff and all the patients and all the students. And so we were going to have this picnic out on the front lawn at Central State. And one of the techs was taking down the Kool-Aid. And the Kool-Aid was in this industrial size jug. And she was struggling coming down the outside stairs of the hospital to the lawn. So I saw the woman struggling with the Kool-Aid container, and I said to one of the patients, "Nathan, could you go help Anna with the Kool-Aid?" And he says, "Okay." And he starts to walk, and then he freezes in mid-step, and he turns around and says to us, "I don't know if I want to go or want to stay." That's a classic example of ambivalence. What is the big deal about going to help the woman with a jug of Kool-Aid? Well, if you have schizophrenia, that is a very difficult situation to assess. Should you go? Should you stay? So, if Nathan has trouble deciding if he should help Anna with the Kool-Aid, what do you think his ability is to decide about things in his life? Like, should I go to school? Should I take my medication? Should I take a shower? You can see how these folks get frozen and they have trouble making decisions. And other people sometimes think they're being uncooperative, but really it has to do with their problems in cognition. They can't assess and make a decision. Okay, now, also, people have impaired relationships with others. Sometimes people with schizophrenia are described as autistic. They're not autistic in the way we generally think about autism. They are autistic in the sense that they are withdrawn from others and they are preoccupied with their internal environment, their own thinking, as opposed to engaging in the world. Okay, we also see this deterioration in appearance. It's very common for people to have poor grooming and poor self-care. And this often is a major nursing issue because you have to get people cleaned up. And it is very difficult sometimes to convince people that they need to wash when they just have so many problems making a decision. So let me tell you a funny story. So one time I was working, it was a Sunday, and we had this patient who apparently hadn't taken a shower in 2 weeks. And the one of the nurses said, well, you're just going to have to deal with him. I thought, okay, well, how am I going to deal with him? I talked with him and I said, you know, you need to take a shower, and I put some towels and clean clothes in your room, meaning a scrub pants and a hospital gown, and this is something you need to do this morning. And he said, okay. Well, time goes by, and it's almost noon, and he hasn't taken a shower. So it was pretty clear to me that he was going to say yes, but not do it. So then it becomes how to motivate this patient. So I thought it over, went out to the vending machine, bought a bag of Grippo barbecue potato chips and a Snickers bar. So I went over to the patient and I said, look at this. These are yours if you will take a shower, wash your hair, and change your clothes. And he said, okay. And he did. Now, the rest of the staff thought this was bribery, and they were right. But E. Fuller Torrey, the physician we saw in the film, and whose picture is earlier in this presentation, has said, we used to call it bribery, now we call it behavior modification. For people who are so severely impaired, sometimes you have to use a little bribery. And what was the harm in giving this poor man some potato chips and a Snickers bar? It worked out really well. He felt better when he was cleaned up, and everybody else around him felt better. Okay, next slide.